Hello everyone, my name is Damali Nakitende. I am one of the ultrasound faculty members at George Washington University Hospital, and today I'm going to be talking about renal ultrasound. So I love the kidneys. So hopefully after this talk you are able to love the kidneys just as much as I do, and we can teach you all about renal ultrasound. The objectives for this talk are you should be able to understand the indications for renal ultrasound. You should understand how to acquire the images of the bladder and the kidneys, be able to identify normal renal and bladder anatomy, as well as recognize the common pathology related to the kidneys and bladder. Before we take a deep dive into what the kidneys look like on ultrasound, I think it's important to do a little bit of an anatomy review. Remember, your kidneys are retroperitoneal structures that are surrounded by gyrotous fascia, and they are next to your aorta as well as your IVC. And when you look at the kidneys themselves, the parenchyma is made up of the cortex, which is this part right here, as well as your medulla, which has these medullary pyramids. And within these pyramids are going to be your nephrons, and of course in your cortex is the rest of your filtration system. And as urine is made, it is dumped into these minor calyces that eventually join to form your major calyces. And then that dumps into your renal pelvis. And then from your renal pelvis, urine makes its way into the ureter and then finally into the bladder. In addition to your parenchyma and collecting system, you also have your renal vasculature, so your renal artery and vein coming through the hilum of the kidney, but also have your lymphatics, which are not shown here, and also, of course, you have a lot of fat that is concentrated within the hilum of the kidney, which affect the imaging that you will see on ultrasound. So very briefly, let's see what this looks like on ultrasound. So you have your kidney surrounded by gyrotous fascia once again. And then you have the more hypoechoic parenchyma, which is going to have your cortex as well as your medulla. And you have this hyperechoic or bright renal sinus that is concentrated of fat and lymphatics, and you also have your vasculature and your collecting system, and that's all concentrated in here. So as we start looking at the kidneys on ultrasound, it's important to know that you have this distinction of the cortex as well as the medulla as well as this renal sinus here. So why do we do this? Who cares? Well, a lot of patients presenting with various pathologies do care that you look at their kidneys on ultrasound because they may come in for urinary retention and need you to look at their bladder. And once again, when we say renal ultrasound, we're talking about the kidneys and the bladder, so the entire urinary system. So if somebody comes in with urinary retention, we're looking at their bladder to figure out whether or not they need a Foley catheter. If they do have a Foley catheter, is it in the correct location? Maybe your patient is one where the Foley catheter stopped functioning and you're trying to figure out, is it in the bladder or is it not? Ultrasound is a quick and easy way to take a look at that. Your patients that come in with a hematuria, do they have a bladder mass? Or maybe your patient has potential for obstructive uropathy. Renal ultrasound is great for that. Or maybe your patient simply is in renal failure and you just don't know why. It's important to know that ultrasound also has its limits, but if you have a patient who is specifically coming in older, has symptoms of maybe renal colic, the other structure that you should definitely consider imaging is the aorta. So make sure if you're considering renal pathology in a patient who is older and has maybe some atherosclerosis or fits the picture for having potential aortic pathology, you also take a look at the aorta. It's very quick and easy. There are limitations for renal ultrasound. Your ultrasound is not so great at looking for retroperitoneal fluid. It also is not so great when it's distinguishing your vasculature from your collecting system, and you definitely have to put color flow on that renal sinus area to be able to distinguish the two. And then when it comes to small stones, ultrasound is not very sensitive for looking at those. I think that it's about 60% sensitive. And then lastly, when you're evaluating your ureters, ultrasound is definitely not very good for that, and you definitely want to utilize CT scan potentially to better get an evaluation of where a stone may be located because ultrasound is not so great. So which transducer do you use to look at the kidneys? I've already shown you one picture of the kidney. So which transducer are you going to use? You're going to use a low frequency probe. So in our emergency department, we carry the phased array probe, but you also have the option of this large curvilinear probe that has a wider footprint. Either one of these probes works well. I prefer this one actually in looking at the kidneys simply because this footprint is small enough to fit between the ribs. And so that's going to be important when we start to talk about especially where the kidneys are located. When you do finally pick your ultrasound probe, so your low frequency transducer, let's say you've chosen this phased array probe, you're going to be imaging your kidneys in two planes. This also goes for the bladder. And this is going to help you decipher anatomy and also figure out what pathology you're looking at. So it's always important when you're looking at most things in ultrasound to image in essentially a coronal plane and then also coronal sagittal plane and then also an axial plane. So let's start with your right kidney. So your right kidney relative to your left kidney. Your right kidney is going to be a lot more inferior but anterior, and it's a lot more inferior because of the large liver that pushes it down ever so slightly. And so when you start imaging the kidneys with your indicator pointing towards the patient's head, you're going to have your probe sitting at the level of about the 10th to the 12th rib. And so when you start in this position, the image that you'll see should look familiar if you've already done your FAST lecture. And what you're going to see is liver, you're going to see diaphragm, and then you're also going to see the kidney, which is located here on the right of the screen. And of course here, once again, just pointing out the anatomy, you have the cortex, and you're actually seeing the renal pyramids here. And then you have the hilum of the kidney that houses the lymphatics as well as the fat, which is what makes it bright white or more hyperechoic. So let's look at a live video of this. And so what we see here is someone who is fanning through the kidney, and what you appreciate is the fascia around the kidney. You're looking at the superior pole of the kidney as well as the inferior pole of the kidney. And you are appreciating the renal parenchyma. Let me pause this. The renal parenchyma as well as the hilum of the kidney like we talked about. And so you're getting an entire view of the kidney, which is the most ideal way to visualize it. So this is your right kidney in long axis. And we already said that one plane is not good enough. We're going to also take a look at the kidney in short axis. So let me play the video one more time so you can appreciate it. So as you fan through from side to side, you get an appreciation for what your kidney looks like. Moving on, you turn your indicator facing towards the patient's left, and what you notice is that your kidney is now in short axis. And so as you fan through the kidney, what you'll also get an appreciation for is the hilum of the kidney as well as the cortex of the kidney. It looks more circular. And then you also, here they marked it out for you, you have artery, vein, and then your ureter as well. And so you will have to obtain these same views on the left side. But remember, the right kidney relative to the left kidney, we said the right kidney is going to be a lot more inferior, and your left kidney is going to be a lot more superior. So when you're taking a look at your left kidney, you're going to start a little bit higher because your left kidney is going to be a lot more superior and posterior. And so you're going to start the level of around the 9th rib, and you're going to start with your indicator pointing towards the patient's head, and you're going to fan through taking a look at the kidney like so. And you get a view of the cortex of the kidney here as well as the hilum of the kidney. And this tends to be a little bit more challenging when people are ultrasounding the kidney on the left side, simply because you don't have that very large acoustic window from the liver, and also the ribs tend to get in the way. So you may have to rotate your probe ever so slightly clockwise, just so that your ultrasound probe can fit right into the space between the ribs so that you can visualize the kidneys a little bit better. So when you turn your ultrasound probe to face or the indicator to face the left side of the patient, then you'll be able to visualize once again your kidney in short axis. And this is just a view where we're kind of going from superior to the inferior aspect of the kidney. And you can see the hilum here as well as the cortex of the kidney. Moving on to the bladder. The bladder for most people is going to lie just behind your pubic symphysis. And so when you're placing your ultrasound probe, you're going to place your ultrasound probe just above the pubic symphysis with the indicator pointing towards the patient's left side. And so as you do this, what's going to end up happening is you are going to have to tilt the probe into looking into the pelvis, and you'll notice that the bladder is going to appear like so, especially if it is full. And as you fan back and forth, what you'll get an appreciation for is a very full bladder for this specific patient. And this is the view that you will want to see if you want to visualize the Foley or even visualize whether or not a patient may have some urinary retention. You're then going to turn the ultrasound probe with the indicator facing towards the patient's head, and you're going to tilt down looking into the pelvis again, and what you're going to see is the pubic symphysis, which is kind of this black area, and then you're going to see the bladder, and you're going to fan from side to side, so from side to side, looking from the iliacs to the iliacs, and you'll be able to get a good view of the bladder in that axis as well. I should be clear that when I'm talking about side to side, you're not actually lifting your probe. Instead, you're just fanning back and forth to get a good visualization of the bladder. So once again, that transverse view is great if you want to just see if the bladder is in a good location. The bladder is in good location, sorry, to see if the Foley is in good location. And in this case, you actually see the Foley catheter in place, and it's also inflated, and this patient still has a fairly full bladder with this Foley catheter. So either they've just placed it or this Foley catheter might be malfunctioning. So nephrolithiasis, I already mentioned to you guys that ultrasound is not so great with picking up really small stones, but in this case we're talking about a 2 centimeter stone, so definitely ultrasound can pick that up. And stones are going to appear hyperechoic, and they're going to have shadowing behind them. So in this case, you also can appreciate a stone here. But remember, once again, for your much smaller stones, if you're looking for a small stone, ultrasound is not so sensitive for finding those compared to other imaging modalities like CT scan. So the next topic, pathology-wise, is going to be hydronephrosis. Hydronephrosis is what you will commonly be trying to find in a lot of the patients that you do renal ultrasound on. And hydronephrosis ranges from mild to moderate to severe. And so as we go from mild to moderate to severe, what initially happens is that you'll have dilation of that renal pelvis. So remember, every image that we've looked at on ultrasound is your hilum has appeared bright white and you couldn't really see your collecting system. However, as it starts to dilate, let's say you have a stone here in the ureter and it starts to dilate, what you will have is that these calyces will start to dilate, but you have preservation of the papillae that are coming off of the calyces, for which the calyces are coming off of, I'm sorry. And so as the renal pelvis starts to dilate more and more, what you start to have eventually is obliteration of that renal parenchyma. And in this case, if you're seeing severe hydronephrosis, this is somebody who's been obstructed for a long time. You should consider CT imaging, looking for masses. So let's see what this looks like on ultrasound. So here you get an appreciation for the kidney and lung axis. And what you note here is that you see kind of these black areas. So this is your renal pelvis, and you start to get a little bit of dilation of your renal of the minor calyces and the major calyces, but you still have preservation of your papillae. The question that you should ask me in this situation, if I was there, is you should say, well, Damali, how do you know that's not vasculature? Well, the way you figure out whether or not that's vasculature is you put color flow on the kidney itself. And in this case, you can see that there's still hydronephrosis that you note even with the color flow, because color flow would help to highlight your vasculature. So in a patient where you potentially see mild hydronephrosis, definitely put color flow in it, because it can definitely, vasculature can definitely look like that. The other way that a patient may have mild hydronephrosis that is not necessarily pathologic is if right now you guys have been in lecture for several hours and you have not had a chance to use the bathroom, you may see a little bit of mild hydronephrosis even in your kidneys, but it should be bilateral. But if you're seeing it unilaterally and the patient has some flank pain, it's possible that they may have a kidney stone. Also, the degree of hydronephrosis may be less in patients who have been vomiting, so maybe they're fluid down. So it's important to kind of use your clinical judgment when evaluating the kidneys. Moving on to moderate hydronephrosis. So for moderate hydronephrosis, what you notice is that now you've completely lost the anatomy of the renal calyces, and you see complete dilation of the pelvis as well as the calyces, and you're starting to get a little bit of obliteration of the actual parenchyma here. You haven't completely lost it, but you're certainly starting to. Moving on to severe hydronephrosis, this is also called the bear claw appearance. Here's an image to appreciate that. That bear claw appearance where you see essentially no renal parenchyma. Here you see a little bit, but still there's still significant dilation of your renal pelvis as well as your calyces, and complete obliteration of those calyces actually. And so this is in long axis as well as short axis. So we've talked about hydronephrosis. Once again, this can be a very confusing topic, so let's talk about it one more time. Remember, your kidney generally has a hypoechoic cortex that is made up of, a hypoechoic parenchyma that is made out of your cortex as well as your medulla, and then the more hyperechoic center in which your vasculature, your lymphatics are housed, and within that is also your collecting system. Your collecting system, generally you don't see it. However, when it starts to dilate, like in mild hydronephrosis, then you start to see dilation of the renal pelvis, as well as your calyces will become a little bit more prominent. And then as you go from mild to moderate, you see that your calyces are a lot more obvious. And then in severe hydronephrosis, you've essentially lost part of your parenchyma. So going from normal to mild to moderate and now severe hydronephrosis. Moving on, we're going to switch gears a little bit, and now we're going to be talking about renal cysts. Renal cysts are very common. They are not always necessarily pathologic. Some people have renal cysts most of their life and don't even know it. Renal cysts generally will be seen within the periphery of the kidney, within the parenchyma. And for most part, simple cysts will appear anechoic or black in nature, and they will not have any internal echoes within them. And it is once again very common to see them within the periphery of the kidney. Every once in a while, you may also notice them close to where the pelvis is. It's just the location of them. And as you start to see more and more of them, you may notice that a patient perhaps has polycystic kidney disease, like in this case, where you see the renal pelvis come through here, and then all you're seeing is cysts everywhere. And you're barely seeing the normal architecture of the kidney that we have been describing. This is a patient with polycystic kidney disease. And these kidneys can be fairly large, and so sometimes you're going into the lower part of the abdomen to even image the kidney in its entirety. Moving on, bladder. Typically, once again, we said that you can see a Foley, but you can also see masses. And so in this case, what you're looking at is a bladder in transverse view. And actually what you see here is a fungating mass within the bladder. So perhaps perhaps this patient presented to the emergency department and actually had bad hematuria. So that about covers renal ultrasound, but it's important to remember that there's some pitfalls that you want to avoid when imaging the kidneys. Remember your renal vasculature versus your collecting system. You have to utilize color flow in order to distinguish the two. You never want to say someone has hydronephrosis when they don't, and it's purely their renal artery and vein. Mild hydronephrosis, your overly hydrated patients or anyone who has a full bladder will have mild hydronephrosis. If your patient has no hydronephrosis though, and you're like, I feel like this patient definitely has a kidney stone, it could be that they're just very fluid down. So perhaps consider giving them a liter of normal saline and then repeating their imaging in about an hour. And you may be able to see the hydronephrosis on the side that is affected. Or perhaps your patient is dehydrated. Otherwise, consider an alternative diagnosis. If your patient has severe hydronephrosis, that is not a kidney stone that has caused that. It is probably a mass that has been sitting there over time or something else that's been obstructing the ureter over time. So strongly consider a CT scan for these patients. And then if you have bilateral hydronephrosis, because both your ureters come to dump into your bladder, then you should definitely consider that you have some type of bladder outlet obstruction. So maybe it's that mass that's taken over where the ureters dump into the bladder. And so you now have bilateral hydronephrosis. So if you see bilateral hydronephrosis, the cause is likely within the bladder. And then hydronephrosis can definitely be normal in pregnancy, just given that that gravid uterus can compress where the ureter is located. And remember, not all flank pain or renal colic is renal. And in that patient who is the right age, maybe older, and having really bad back pain, you definitely want to take a look at their aorta. Thank you so much. That will be about it. Hopefully we get to scan together and talk more about the kidneys the next time I see you.